One of the more common problems that we encounter in private practice is that of evaluating and treating heel fissures, period. These can present as relatively minor problems or actually present as very significant, painful problems at times, particularly in immunocompromised patients, patients with vascular disease, patients with other systemic illnesses. These problems can become rather significant with infection and even ulceration. So I thought we'd spend some time looking at the problem of heel fissures with a special emphasis in the diabetic patient. When patients present with heel fissures, differential diagnosis basically is listed here. At times they are associated with skin xerostosis and possibly the presence of pseudomotor deficit. So we tend to see this as part of a general loss of sweat function in patients with small fiber neuropathy, secondary to autonomic neuropathy, something that's rather underappreciated in the diabetic patient. We also will see xerosis with fissuring in patients who are hypothyroid. It may be a manifestation of palmoplantar keratodermia, may be a manifestation of psoriasis. Tinea pedis may present with scaling and fissuring of the heels. Atopic dermatitis may present in this manner, and sometimes exposure to winter dry air. So this would represent, I think, a reasonable differential diagnosis for skin xerosis. With reference to thyroid disease, we do see the heels cracking and fissuring in patients who are hypothyroid. They may be treating for hypothyroid disease, or they may be undiagnosed. In looking at these patients overall, we have a patient in front of us who has generalized complaints and concerns, generalized arthralgias, tendinitis. When questioned, they say, I do tend to feel cold. They tend to be overweight with peripheral edema. They have generally dry skin, and when questioned, dry hair. Generally looking at these patients, we get the sensation that they may be hypothyroid. If their general appearance and questioning is consistent with low thyroid function, one can certainly do basic screening as part of the differential, getting thyroid stimulating hormone. You could get a T3, T4, or just a T4 with a thyroid stimulating hormone. The findings are in front of you, and you can see that there is generally going to be increased thyroid stimulating hormone in an effort of the body to rev up that underperforming thyroid. Generally in clinical hypothyroid disease, T4 will be diminished, and T3 early on will be normal but later decreased. So one can order basic screening testing given a patient with significant fissuring and cracking and a general presentation suggestive of hypothyroid disease, or perhaps pass a note back to the primary care doctor suggesting that this disease in the heels may be representative of a more global process. Usually, more classic disorders such as palmoplantar psoriasis are not characterized solely by fissuring and cracking, may be presenting with pustular type lesions, vesicular type lesions. Palmoplantar keratodermias generally present more dramatically, and heel fissuring and callousing is just one of many manifestations of the disease. Atopic dermatitis is also included in the differential diagnosis, and one can attempt to elicit a history of atopy, allergies, look for facial manifestations of atopic dermatitis. Now, with reference to the diabetic patient, we know that studies of skin disorders in the diabetic patient frequently show that one of the, if not the most common skin disorders in the patient with diabetes is that of skin xerosis. And this affects, in some studies, greater than 40% of patients with diabetes, and also tinea pedis, and as you know, onychomycosis. And oftentimes, tinea pedis is mistaken for skin xerosis. Here's another study, again, looking at the incidence of skin disorders in diabetic patients, and we see again that skin xerosis is reported in this particular study also as being the most common manifestation of diabetes in terms of skin disorders. So this is not at all uncommon in our diabetic patients. Looking at skin disorders with reference to xerosis versus tinea pedis, we see that as with onychomycosis, when tinea pedis is present, it's usually dermatophytic in nature, and T. rubrum is normally the most common organism recovered, and the most common mistake or misdiagnosis is dry skin, rather than understanding this is in fact a fungal infection. So when we see xerosis of the skin on the foot, and when we see cracking and fissuring of the heel, we do want to consider the possibility that it is tinea pedis and not just callous skin and dry cracking skin. So the patient may not be responding to emollient therapy or seemingly appropriate trophic skin care because in fact they're manifesting a tinea infection rather than just simple skin xerosis. If we look at patients who present with these problems, over 50% of the time the patient has manifestations of peripheral autonomic neuropathy with loss of sweat function. They have a pseudomotor deficit, and this is very important to detect, because patients with peripheral autonomic neuropathy frequently have cardiac autonomic neuropathy. They may have other manifestations of autonomic neuropathy, and this can be associated with significant morbidity and mortality. Peripheral edema, for example, due to venodilation may also be present. So we may have dry cracking heels, we may have generalized dry skin on the feet, we may have swelling, and again, this is a manifestation or may be a manifestation of diabetic autonomic neuropathy. We know that autonomic failure is reflected in no small part by loss of sweat function in patients with autonomic neuropathy, and this is due to loss of cholinergic small fibers which innervate the peripheral sweat glands. Although we typically view the keratinocytes in the epidermis as being rather benign and passive, they do in fact possess neurotransmitters and do have receptors. They do respond to temperature as well as mechanical stress and chemical stimuli, and are very, very important in management of the peripheral skin neuroendocrine system. Now, why treat heel fissures? Why be concerned about them? Because whether they're due to skin xerosis or tinea pedis, or perhaps changes secondary to hypothyroid disease, in the presence of neuropathy and peripheral vascular disease, these fissures can result in infection and ulceration. That being the case, then, when we screen patients, how do we go about evaluating and treating these patients? A variety of treatment modalities are present for use in the treatment of heel callousing, heel fissuring, and it's difficult at times to discern which patients will respond to which treatment. Urea has certainly been a basis for treatment of these problems over the years. One can use higher percentages of urea. We can combine this with salicylic acid. Again, when these lesions are painful, we can compound up a medication such as urea plus salicylic acid plus lidocaine. We can also include urea mixed with topical antifungal agents. Again, the majority will be trichophyton rubrum. However, one could incorporate fluconazole or itraconazole as well as terbinafine topically. You can include topical antibiotics together with urea. So that again, if we get into this concept of looking at that foot and saying, what is it that I need? It is certainly possible that the patient will be best served by you deciding on a broader spectrum approach and going ahead and compounding the appropriate medications rather than picking one particular product that may or may not be effective. Salicylic acid alone can be used. The alpha hydroxy acids have been advocated for treatment of heel fissuring. Saccharide isomerate products have also been advocated. As mentioned, oftentimes there's a component of tinea pedis involved in these presenting heel fissures and dry skin, and you may elect to proceed with isolated antifungal therapy, or again compounding a topical antifungal together with urea or salicylic acid or alpha hydroxy acids, whatever you think is appropriate for the aggressive treatment of these heel fissures. Initial applications are recommended at least 3 times daily. It is helpful to incorporate therapy or to provide therapy to reduce the thickness of the keratotic tissue to allow better penetration of the medications through the skin, and then generalized measures. Weight loss is certainly something that needs to be recommended in a number of patients, and there's oftentimes a reluctance to discuss this with patients, whether it's with heel pain or arch strain or other problems, but I find and have found over the years that patients are appreciative for the honesty, and I think they need to be confronted and told that oftentimes their weight plays a role in all of this. Edema reduction is similarly helpful, and here again we want to watch for the patient with peripheral autonomic neuropathy and pseudomotor deficit that may be venodilated, and edema reduction should be incorporated in your therapy in patients in whom that's considered to be an additional factor. Reduction in weight bearing can certainly be recommended if that's possible. No open back shoes or sandals. It's generally felt that open back shoes contribute to heel fissuring and scaling. And in some patients, particularly where there is dispersal of that plantar fat pad or atrophy of the plantar fat pad, heel cups may be beneficial and recommended. As a practice management point, there are a number of ICD-10 codes that may be applicable for treatment of patients with heel fissuring and scaling absent a specific diagnosis, and they range from changes in skin texture to fissures of the skin, other specified disorders of the skin and subcutaneous tissues. Xerosis cutis is appropriate in some individuals, as are diagnostic coding for tinea pedis, so that a variety of ICD-10s may be appropriate. So what about the business of heel fissures, if you will? Patients present with this problem. We conduct an initial examination and consultation and make our initial recommendations. We want to consider whether additional studies are appropriate. In some patients in whom tinea pedis is suspected, fungal cultures or skin biopsy may be appropriate to rule out the presence of fungus as a cause of the fissuring or as a comorbid condition. There may be more than one etiology. Skin biopsy may be appropriate if one is considering the presence of other dermatologic conditions. In consideration of autonomic neuropathy, sweat gland biopsy is considered. This can be done with a 3mm punch and looking at innervation of the sweat gland to see whether or not there is evidence of loss of sweat gland innervation. Vascular studies, if one feels that there's an element of peripheral arterial disease, particularly to the arterial supply going to the heel, and necessary laboratory studies. One might screen the patient for things such as undiagnosed diabetes or glucose intolerance, or more commonly hypothyroid disease. We then want to prescribe appropriate therapy, and again, oftentimes, at least in my practice, it will be a compounded preparation of something that may be keratolytic, such as urea creams, which also have antifungal activity. We may include some salicylic acid in that. We may incorporate an antifungal most commonly terbinafine, and if the heel fissures are particularly painful, then we'll also incorporate some lidocaine. And we want to initiate therapy to reverse autonomic neuropathic changes when they are present. Most commonly in my practice, this will include vitamin B complex. And the reason is that there is literature that would suggest that vitamin B complex, particularly folic acid, B6, B12, in active forms is helpful for reversing changes present with autonomic neuropathy, and then prescribing or dispensing heel cups or other appropriate mechanical therapy. So initially, want to conduct a consultation with the patient, discuss the differential diagnosis, the fact that this should be treated particularly in immunocompromised patients, patients with vascular disease, patients with diabetes, as this can present a risk for infection and potentially ulceration, and follow up as needed. With reference to peripheral arterial disease, we want to ascertain or evaluate the circulation for the calcaneal branches of the posterior tibial artery and the peroneal artery, because as you know, we have angiosomes that specifically supply the heel, and we want to try to assure that vascular supply is intact to these areas and that we're not seeing an early manifestation of vascular disease. Evaluation of arterial disease can also be done simply in the office, clinical examination and Doppler examination, looking also for other manifestations of peripheral arterial disease. If there is a differential diagnosis, if one is concerned about some other dermatologic disorder, then punch biopsy is generally an appropriate test to consider. In other circumstances, a shave biopsy, excisional biopsy really is not appropriate here. We're usually reserving that for neoplastic lesions, more isolated lesions. So generally a punch biopsy 3 millimeters would be sufficient for our needs. In looking at autonomic neuropathy and loss of innervation of the sweat glands, we want to remember that the autonomic nerves innervate the peripheral vasculature, regulating vascular flow to the skin as well as innervating the sweat glands. And so oftentimes we will see some vascular compromise at the small vessel level associated with autonomic neuropathy, just as we see loss of sweat gland innervation. In looking at the diabetic patient, it has long been known that pseudomotor deficit is associated with autonomic neuropathy. It's associated with an increased risk of ulceration, and when we screen patients with diabetes for risk of ulceration, we do want to include examination of patients for the possibility of autonomic neuropathy. And here's such a foot where we see generally dry, scaly, fissured skin. And instead of just writing this off as simple xerosis, we may want to consider the presence of autonomic neuropathy. So there is specific testing available for this. There is sweat gland nerve fiber density testing. I think most in podiatry are familiar with epidermal nerve fiber density testing, and this is done in a similar manner. We go ahead and get a 3 millimeter punch biopsy and have this stained for innervation of the sweat gland. So that's a sweat gland nerve fiber density test. This is from the Therapath laboratory in New York, and it's an example of such a test where we've done a 3 millimeter punch biopsy, and to your left you could see a normally innervated sweat gland. To your right you see decreased innervation of that sweat gland, and again this can be a manifestation of autonomic neuropathy and loss of innervation to the sweat glands. Now, there's a relationship between autonomic neuropathy and homocysteine levels, as there is other forms of diabetic neuropathy, meaning sensory and motor, with autonomic neuropathy and homocysteine levels. And we know that elevated homocysteine levels are a risk factor for autonomic neuropathy because, in part, they are responsible for a vascular occlusive disease. So we know that homocysteine is a non-essential amino acid. It is essentially thrombogenic agent. It is active to decreased vascular supply to nerves and essentially causes a form of ischemic neuropathy, if you will. And autonomic neuropathy is associated with ulceration and Charcot's joint disease. And again, when we look at these patients, we generally see sort of an erythematous hue to their skin. We see dry, scaly skin. And this is a manifestation of both pseudomotor as well as vasomotor deficits secondary to their autonomic neuropathy. A number of papers for many years now have suggested that one can reverse, in some patients, certainly not all, autonomic nerve signs and symptoms, and even normalize autonomic nerve dysfunction by the provision of methylcobalamin. And this is something that one can consider nutritionally. With reference to laboratory studies for low thyroid function, again, in general, we're going to see with primary hypothyroid disease elevated TSH, because we're going to see efforts to stimulate thyroid function. If we look at thyroxine levels, T4, with primary hypothyroid disease, we see elevated efforts to stimulate the thyroid, that's elevated TSH, but we still maintain low thyroxine levels. If we have subclinical disease, we initially see elevation in thyroid stimulating hormone, but we have normal levels of T4. Later on, with secondary disease, we have low levels. So what about topical therapy? One can prescribe topical agents. One can dispense topical agents for the treatment of skin xerosis and heel fissuring and heel tinea pedis. So what are some of the things that one can prescribe or recommend or dispense? Well, we have standard pre-made over-the-counter products, and some of them have been shown to be relatively effective in some patients. Things such as shea butter. Here in St. Louis and in the Midwest, bag balm is commonly utilized. Honey, avocado, olive oil have been used with some success in some patients. We have standard pre-made, pre-formulated products that are marketed specifically for skin xerosis and heel fissures, and one can certainly prescribe or dispense these products. You can individualize your therapy, which is oftentimes preferable, and that's, again, by compounding. So I will look at some of these patients and say, what is it that I think they need? Are they painful? Do I have evidence or a suspicion there's a secondary tinea pedis or bacterial infection? Is there an evidence of vascular disease? So I can go ahead and prescribe a keratolytic like urea or salicylic acid. I can include something for pain. I could include an antifungal topically or an antibacterial. I could use an antibiotic or antiseptic. And if necessary, I could also include something that's vasodilatory. I could incorporate something like pentoxifylline or a calcium channel blocker. So one can prescribe urea-containing compounds, and they are available in various percentages, various concentrations as pre-made. Now, one advantage of compounding is that you're not restricted to particular strengths. So within reason, so long as the compounding pharmacist is comfortable with your prescription, you're not restricted to particular concentrations. But there are a number of products that are available that are pre-made and can be either recommended or dispensed to the patients. Alpha hydroxy acids and emollients have long been advocated for heel fissures and may be useful in lesser expressions of the disease. Saccharide isomerates are also available and again are sometimes helpful, primarily I think for lesser expressions of the problem. Shea butter is quite popular. It's a fatty compound which is extracted from the African shea tree. It contains a number of organic acids, including stearic acid, oleic acid, linoleic acid, palmitic acid, and arachidonic acid. It's anti-inflammatory, it's a humectant, and some patients seem to do particularly well with these products. Bag balm is hydroxyquinolone and quinolone, and it is helpful for a number of patients with heel fissuring, and it's not uncommon to have patients use this with very, very satisfactory results. Heel cups, again, something that can be recommended or can be dispensed, and for many patients this is quite helpful for the treatment of heel fissures. A number of callus removing products are available. They certainly are going to be helpful in reducing the thickness of the callus and increasing penetration of medications. However, I think one has to be selective in recommending or endorsing the use of these products. From a personal standpoint, I am not comfortable recommending the use of any of these products at in high-risk patients. So the diabetic patient, the patient who's immunocompromised, certainly the patient with peripheral arterial disease, I'm not apt to endorse the patient utilizing these products. So in summary, there is a differential diagnosis associated with heel fissuring. It may be a manifestation of tinea pedis. It may be a manifestation of skin xerosis. It may be a manifestation of small fiber neuropathy with pseudomotor dysfunction, and it may be a manifestation of endocrine disorder, particularly diabetes or low thyroid function. There is a differential diagnosis involved. I think the most important is that of tinea pedis, and whether or not one has a concurrent tinea pedis or the tinea pedis is manifesting as a heel fissure. Obesity is certainly a common component of all this. As far as treatment goes, again, urea-containing compounds are helpful. Salicylic acid, alpha-hydroxy acids, saccharide isomerate. Antifungals may be utilized isolated as isolated therapy or incorporated with other topical agents as a compounded medication. You want to encourage use of these products at least 3 times daily. You want to encourage or provide callus reduction to allow greater penetration. When appropriate, weight loss should be recommended. You should incorporate efforts at reducing edema when appropriate. Recommend reduced times standing. Try to interdict the use of open back shoes or sandals, and utilize heel cups when appropriate. Thank you.